Well, hello everyone. New studio on managing very high-risk situations. So it's going to be a punchy session. We're going to have 3 big blocks in these high-risk situations. The first block will introduce you to the concept of protected angioplasty. Then we'll move on to the analysis of a molecule that's a little too little known, Cangrelor. For some of you, this may sound familiar. Perhaps for others, you'll discover it. And finally, we'll finish with the patient at very high risk of hemorrhage, which is truly a daily theme, because we have more and more of them, and we'll have more and more to deal with. So this studio is sponsored first by Biosensor, then by Bioprojet, and finally by Alchemedics. So as we're a little pressed for time, we're going to start straight away with the concept of protected angioplasty. And I'm going to ask him to give us a bit of a rationale. And then what do we have in the literature? What are the principles of this protected angioplasty? Who is it for?
Thank you, Jacques. So I'm going to do this in a bit of a sprint to say, first of all, that there is very little data to provide us with proven scientific evidence, but there is common sense to be injected, and there is great variability in the use of these hemodynamic assistance techniques during complex plastic stakes. And why such heterogeneity? We can discuss this later, but it's probably also the result of experience acquired in the field. When you don't have experience, you don't necessarily use this type of assistance, which can be of service to certain patients. And I'm one of those who use it very little, so I'm quite comfortable saying so. This slide shows, on the one hand, that there are real fluctuations in the use of these hemodynamic systems to improve patient care during very complex procedures, and that there is probably also a fluctuating use of new equipment with a very wide standard deviation between centers. So basically, we're not all at the same level of use of this type of device. So how do we select patients who should or can benefit from these hemodynamic improvement techniques during complex angioplasty? Well, first and foremost, on the basis of hemodynamic data. When the patient's left ventricular function is very impaired, when his blood pressure is very low, all these data are extremely logical. This plate shows you that we can calculate scores for patients, notably on the basis of hemodynamic data, as I've just said, but also on the basis of comorbidities. We all know the importance of aortic narrowing when we perform a procedure such as a rotablator on an extremely calcified coronary artery, and we know that these patients are highly exposed. And then the anatomy of the lesions, so when you're going to do a multi-vessel, when you have to deal with very complex lesions, use rotablator, as I've just said. So there are 3 factors: hemodynamics, comorbidities, and the complexity of the angioplasty procedure. This slide, which I recommend you look at if you're interested in this topic, shows very clearly how patients are selected and the different techniques that can be used, from intra-aortic counterpulsation to ECMO, for the different clinical situations mentioned. We're going to focus on IVA, IVAC, which is, I'm not going to go into the technical details since Guillaume is going to show us. Simply this first paper in 2017, materializing experience on 14 patients, so not many patients, who show very clearly that hemodynamics is improved during the procedure, very clearly with blood pressure, but that this hemodynamics, which is improved during the perioperative period, continues afterwards for these patients at the cost of a comorbidity which is not negligible. As you can see, there are still complications at the point of function of the order of 8%. Here we have a much broader experience, this time involving registries in many countries, as you can see. 293 patients were included, mainly with complex multivessel lesions treated by angioplasty. What we can see is that there are relatively few MACEs, 3% in an extremely exposed population, with around 9% of episodes of arterial hypertension. But what we will remember is that in this experiment in significant centers, since there are quite a few patients, we can see that the MACE are relatively low, with, I won't go into the perioperative hemodynamic effects, but very clearly very satisfactory effects. But, so when we compare this technique with intra-aortic contribution, we can see, unfortunately, the numbers are small, but we can clearly see a tendency towards hemodynamic improvement and, above all, an improvement in prognosis without this being statistically significant. Another thing we can see is that there is also a tendency to have more vascular complications, which we will be able to control later on, since we have learned with Otavi to control this type of complication, and we should be able to do so. Here, just to refocus on randomized controlled studies, there aren't many, Guillaume, but there are a few. And for intraoral contribution MACE edits, it doesn't improve efficiency. This tool is not relevant in this type of situation. And when we look at all the randomized studies, it's rather on heavier modes of assistance that we manage to detect a benefit and a remote benefit in extremely exposed populations. So to conclude, we're really in a gray zone, but that doesn't mean it's not an area we need to explore. The safety of devices needs to be a little better documented, and the potential benefit, as we've seen, there are strong indications that it works well in the perioperative phase and continues to do so in the postoperative phase. Above all, we've already started randomized studies that will give us much clearer ideas. Thank you for your attention.
Belongs. I'll ask Guillaume right away, perhaps. Thank you, Kim. You've done a great job of setting out the problem. It's really a new concept, and that's what's interesting. And Guillaume, you have the good fortune in Bordeaux to have developed and introduced this concept. Please explain how it works, setting it up steps, and what to expect afterwards. You're going to give us a very nice link to a patient you treated with this technique.
Just so, let me just say what a pleasure it is to be with you today and to be with you both. Because it's also difficult to talk about evolution, to talk about new approaches when you have a little less experience. So we need to approach our work with a great deal of humility. And I believe that protected angioplasty is somewhat at that crossroads of discussion between people who treat patients with scores above 6. You mentioned Brick's article, and that we've been doing this for 20 years, that we've been doing I don't know how many angioplasties. No, 20 years, Hakim. And finally they said to themselves, what's the difference today? Why am I going to put in an 18 French device to give me some security on this patient's story? We all have stories like that, or at least that's what motivated me to embark on this adventure. It's the stories that mark us. Young patients with slightly altered VG. Not always critical situations, but moments where we dive in. Sometimes we underestimate the cherished hurdle we face, underestimating the challenge. The problem is that we don't have much of a backup mode. You can't restart the game at the beginning, even if we'd like to sometimes. And unfortunately, it's true that you can't be in a Mustang without a seatbelt these days. But there was a time when no one would even think of wearing a seatbelt. So that was the preamble. I don't know if it's appropriate, but that's how I feel. The story of saying that these are things that are recent, and these are things of today. In fact, it's a very long story. In fact, there's a very long history of protected angioplasty, which is rather North American. As you can see from the centers that perform protected angioplasty with IVAC. In fact, these are issues that affect many countries, which may have other reimbursement systems, which may have fewer patients to whom they can offer it. But they may have a few more resources. There are many expert centers. So it's a long-standing adventure. It's an adventure that's in other centers. So it's not a village of diehards from Bordeaux offering you their experience on 15K. It's a much broader picture. And it's with a device that's a little more precise today. So I have the IVAC in my hands. I'll show it to you. Basically, it's to show you that the désilé is quite friendly. I think it's pretty flexible. It's 18 French. Maybe we'll have a new one soon. You can pass it on if you like. I think it's important to touch it to get a feel for it. What I see, what I tell myself. In fact, beyond all the technical aspects, it's that the femoral approaches with the structure, I think that this is less of a problem today, and the impeller problem. It can also be a problem with IVAC. The only time we lose, we may have more endematomas, more complications with the approach. There's been a studio on the approach here. There are even studios dedicated to PCR on the approach. I think we've expanded our toolbox. We have a number of devices that mean that even our fellow surgeons do percutaneous ECMO. Pre-closing prostyle or possibly MANTA. So it takes us a step further. And that's what's interesting. A very short video. To give you a practical idea before we go live in the box, a right or left femoral approach of your choice, we use a rather rigid guide that will have inserted intra-AVG. So the catheter you have is flexible, so it's 17 French, a stem that's quite flexible, but it's still 18 if you put it in a stent. Positioning is intraventricular and also supraventricular. We did a few cases in Bordeaux, and I must admit that initially it wasn't necessarily obvious. But there was very good suprahemodynamics with the right catheter. And in the supraortic position, if there's a surgical valve, or if there's a valve that you don't necessarily want to cross. So, as not to damage the leaflets, the membrane is a gas that is absorbed and released. It absorbs blood in the ventricle and rejects it in the supraortic. So it's helium. And we use the consoles you may still have in your 4 labs. Counter pulsation consoles, so in the end, it's greenwashing for you. We were talking about this with the active balloon. Well, it's the same thing here. You're reusing equipment that's in your cupboards and no longer in use, and that allows you, at a lower cost, to have a device that is distributed in France, and which enables you to administer the protected antibiotic in good conditions. So we can go up to 2 liters or even 2.5 liters, which still gives you an interesting support. For the moment, it's not something that can be used as a continuous carrier. But in any case, for complex angioplasty, it may enable you to get through and have significant support. So I'm not the fruit. I'm just a young interventional cardiologist at the beginning of my career. I'm not going to tell you the story. That's not the idea at all. I'm the fruit of a culture. I'm the fruit of a team. And I grew up in a school, in the house as we call it in Bordeaux. And in this house of cardiology, I've always seen angioplasty as protected. It was Frederick Cassasius who started it back then. He's now in the clinic opposite, but we still have a good relationship with him. Today it's Benjamin Segui who also runs this program. I grew up in this culture, and that's why we've done 15 cases today. Very heterogeneous, and that's what makes it so difficult. And it's funny because you're going to say it's got nothing to do with it, but in mitral disease we had more trials. We had trials against repair, and in protected angioplasty it's the same thing. Why is that? Because we label it complex angioplasty. And how do you define it? As we saw with Hakim, there are 3 dimensions. So there are patients who just have very impaired LVs. This is really advanced heart failure. Some patients just have very complex angioplasties. And then there are patients who are just extremely comorbid. They're not surgical, and yet you still have to go in. And so, in fact, this mix of heterogeneity means that for us, as cardiologists with a human intelligence not driven by tools, sometimes we find it a little hard to select our patients. So eventually, we'll be able to offer you the LIAP. A patient, 85 years old, everyday life, a pre-TAVI workup, 85 years old, complex tritonuclear coronary lesion. This is a patient, after all, like many of you, referred to you by an Aquitaine TAVI network center for a pre-TAVI checkup. In paramedical terms, nothing special. Aortic stenosis and renal function in line, I would say, with his 80 years of age. Here is the diagnostic coronography, which shows a stenosis of the right. Coronary stenosis 2, which appears to be quite tight. The left network is not visible. We also see a stenosis of the proximal portion of the CX. And here, we can't see the hemodynamics because, well, it wasn't in our case, but there's pressure in the trunk, which means that sometimes the operator disengages and FFR isn't possible. And we guess an osteal stenosis of the common trunk. And then likewise, we look at the CT scan. There's a growing culture of doing CT scans on these patients and looking for coronary lesions on the scan. We predict an advanced calcification atmosphere on this common trunk, requiring us to fine-tune. We're going to have to take our time in a high-risk area associated with valvulopathy. Here you can see the CT scan. So the femoral approach is not hostile. It's not a hostile femoral approach, let's be honest. But it's not a femoral approach where you want to make 2 passes of more than 14 bangs. In terms of aortic planning, as you can see, we mimic the valve we want to implant. We can see the relationships with the coronary ostia to try and get an idea of how the procedure will go and the timing. Do we first do the vortex and then the coronary lesions? Which vessel are we going to use? Do we know about alternative routes? We can all have this discussion together. Before seeing the boxing plane, I don't know Jacques, Hakim, or even in the audience. What would have been your discussion and what would have been your strategies discussed in the R team?
Well, part of the answer was delivered this morning on the live show. I don't know if you attended the live show, which was a really nice live show in Marseille, where they had a very tight aortic narrowing with a very calcified lesion at the end of the trunk and the circumflex. And the option was chosen to perform TAVI. And as you just mentioned, to avoid having to perform ablations on fragile patients several times, to perform angioplasty right afterwards, having integrated, of course, both procedures into the strategy to avoid doing too much aorto for the contrast medium. So more and more, whereas in Massey we tend to do coronaries before TAVI, even if coronaries are complex, we're seeing a trend where tight aortic stenosis is a very high-risk hemodynamic population. Front valves are increasingly used.
Sequential or combined angioplasty with OTAVI, I'd still qualify that. It's not really our practice because it involves a lot of diode injections. Sometimes the rooms are not exactly the same. For example, in our hybrid room, we don't necessarily have the full range of imaging and treatment options for calcified lesions. And then there are the teams. Because we work as a team, these paramedical teams who make a huge difference in difficult situations, who aren't necessarily as well trained, so are we.
We just don't do it in the same way. Yes, that's right, we don't do the same procedure. But more and more, we prioritize the valves in very complicated patients before performing the coronary network.
That would be suspenseful. So the R team's decision was not to proceed with surgery. The R team's discussion with this very high-risk patient was a combined procedure of OTAVI and angioplasty. So I invite you to share this LIAB recorded with sound that we did with Dr. Benjamin Segui. It lasts 7 minutes, which I'll share with you, and then we'll debrief afterwards. Hello everyone, welcome to this GRCI live inbox from Bordeaux. I'm lucky enough to be with Benjamin Segui. Hello Benjamin. Hello Guillaume. Today we're lucky enough to be with Dr. Gaspar Cadi, anesthetist, and Romain Emanuela, eye-body and circulating nurse. So we're proposing a hybrid procedure, one that's both coronary and structural, for a patient presenting with tight aortic stenosis and tritruncal involvement. A TAVIR procedure that is ultimately standard, mini with just a straight radial approach, a simulation.
Is pacing effective? Yes, the injection is effective. I need every last one. That's it. We can put everything in.
So we systematically measure the gradients before and after TAVIR. There's no gradient, so it's a good result. No leak, good gradient, so we can move on to the coronary sequence.
First, we'll insert the IVAC catheter with the newly implanted valve to be in a supraortic position, which allows us to achieve a hemodynamic effect of 1.5 to 2 liters of support, which for the protected coronary plastic issue is quite satisfactory.
Stiff guide, Boston Super Stiff, on which we mount our DIOHR mesh gradually, I'd say cautiously. The DIOHR wing. How many francs are we on, Benjamin? 18 French. The steps are simple. Simple, you go up and then once you're in position, we finally remove the catheter that's inside. And once the catheter is completely withdrawn, you can clamp the device. The device will
So
go back. Ensure no leaks to avoid risk.
So, with water, it's really four-handed. So we put as much water as possible on the system and try to stick together. So there.
Bubbles. What we do is we can eventually downgrade, then it's bubble hunting time. We check that there are no bubbles in the system before launching the assistance.
Here we see the IVAC being launched. You have this membrane, which is inflated with helium and which will inflate during diastole and deflate during systole. We see a pump-like effect with increased systole and decreased diastole.
As you can see, the ostium is just at the level of the first cell of the TAVR. So we start with pre-dilation.
With a 2.530 minute balloon.
This was expected on the CT scan, as there was no large calcium mass. We pass a 3.036. We have good support with an AL. We leave the ARBP on for 30 seconds and see that we have good hemodynamics during the procedure. The IVAC is stable in the ascending hortus.
So we post-dilate the stand that has been put in place.
We have a good opening.
So we move on to the left trunk angioplasty, still with the IVAC.
Positioned supraannularly with good hemodynamic support. There are no amines currently in place. We're just using IVAC. What we can note is that we're using an EBU 3.5. We could have done with a 3.0. In post-TAVR, it's often advisable to use carriers that are half a size smaller. Here, with the 3.5, as we're a little above the stent valve frame, we're not bad. Okay, I think so.
We're good, aren't we? We're right on the edge of the trunk.
Come on, we can inflate. We can ride the ARBP.
14.
You can see that we have good hemodynamic support during inflation. In the CX deflation.
Let's refine this first stand in the left network with a post-dilatation.
3.513, which will post-dilate at the ANC. Perfect. The CX is fine.
So we switch to
We'll
the...
do stepped pulses. Deflation. We've got good expansion here, so we're going to move up a little on the ostium. Shockwave will be 1-to-1 in relation to the diameter of the artery. We've focused on the diameter of the distal IV. Deflation. Go ahead, inflate. We'll do some more pulses here. The expansion wasn't too bad, but the bulk of the calcium was really in the trunk. This is certainly one of the advantages of the protected plastic angle. The hemodynamics are perfectly stable and we really have time to work calmly and concentrate on the lesions. You don't have to expect to have a poor hemodynamic tolerance that's going to cut the procedure short. Maybe we'll let him breathe a little in between.
So we can see the alteration in the AVAC.
We now have an amine with a 52 map, which is the lowest we've had since the coronary sequence. Coronary sequence.
We'll have done 110 pulses. With an expansion that is... Expansion. We're willing to go to the ostium. We can see that the ostium is sick.
Let's go.
Now we can really take the time to let it inflate properly, to do the 30 seconds at RBP. As you can see, hemodynamics are very well tolerated. Deflation, we're still without amine. We'll do the potty. This is where you really need to optimize. This is where we did almost 80 shockwave pulses. This is where we had anticipated the scanner or deflation.
We estimate that in the end the CX and IVA have the same caliber proximally, so we take 2 balloons.
3 to 5 to make the final kissing.
That's it. Always the right hemodynamic support.
The final part is of course always a little more proximal. We'll give ourselves a small injection. We're always careful not to snag the stunt. Remember that we have a UBE 7F. I think we still have a good result. Always take a good look at the distality. Make sure there's no perforation. No worries. On the distal bifurcation, we're fine. We have all the side branches. Geographically speaking, at least, we've got some stands that seem to be wide open. Now we're going to switch to 1-on-2 on the IVAC. We're going into weaning mode. Just like with a counter pulse balloon. Now we're in weaning mode. We'll remove it in 2 minutes. We'll be able to stop the IVAC.
So we've stopped the AVAC. Now we can restore some of the blood that's in the system. It's good. Okay, perfect. Parfait, parfait.
As you can see, it's very easy to get into I6. It's good to do it under scopic control, though.
For the end of the closure, we'll use a Safari for a rigid grid, or the stiff Boston Super Stiff. And of course, we'll put on the désilé skirt to avoid the walking effect. Thank you all for this structural and coronary live in the box. We would of course like to thank all the biosensor and PulseCat support teams for this procedure, which demonstrated good hemodynamic stability, despite several rather risky sequences. We would also like to thank the entire team, both paramedical and medical. Thank you all very much.
Bravo, Guillaume. You really showed us protected angioplasty as we understand it with this IVAC pump in supraaortic position. So we've seen that you've stabilized your hemodynamics, enabling you to work on and manage calcified tritrancular lesions on which you've performed shockwave. I don't think you were able to do IVUS for purely technical reasons, but you would have had time to do it. So you put yourself in the best possible position to optimize treatment of these coronary lesions.
Yes, absolutely. I think that's important. It's about safety. And we had anticipated that it wouldn't be such a complex issue. And finally, at one point, you saw that we worked on the trunk with several shockwave sequences. In fact, it's not a waste of time to have monoventricular assistance. And finally, we saved time by being able to work continuously. And MAPE, at one point, was well supported. As you can see, I've put this little slide on the support, which is mainly in diastole. And this really allows us to work in good conditions. Progression in 1 month post-op was quite good. Just on the side of your life, there was a huge classification on the non-coronary colossus, a right branch block and a short membranous system. So there was a post-notice pacemaker, even if our rates are rather lower and lower since we put them higher and higher. And the prescription that came out was the dual antithrombotic therapy that you're familiar with no change in the other therapies. In conclusion, telling you the things you already know is the gray zone, it's the discussion, it's the boundary between randomized data, science, and your clinical intuition. The most important thing is that it's safe. It's a technique with which you're familiar and which gives you a great deal of security. The question is patient selection. Of course, it's a multidisciplinary discussion and it's a team discussion. It's randomized. And also, if you're joining the program with IVAC, or even more widely, we're starting the French register with Bordeaux. So don't hesitate to come and join us. Finally, I think there's a new specialty on the horizon: interventional heart failure, with the return of hemodynamics to the front line to better phenotype our patients, both for the valve and for heart failure. And also, I think, when everything is combined. And so the return of catheter evaluation is very evident in the selection of our IQ speed. And I'm convinced that soon we'll be able to better phenotype our patients with catheters so we can better anticipate which patients may need more advanced protection for complex angioplasty. I hope you enjoy the symposium. Thank you for your attention. Let's continue.
Let's move on to Cangrailer. In my opinion, this molecule is far too confidential. And I'm going to ask Paul Guaragnier to join us, Thibaut to the Hermusier from Toulouse, and Anne Gaudier from PHP to join us. We'll have a little chat at the end of the 3 topos. And Paul, I know that you have a great Cangrailer experience. You follow in the footsteps of your masters, of Gilles, and that's obvious. So we'll let you have the floor for
6 minutes. Thank you very much, Gilles. Good day to you all. I'm very pleased to be able to talk to you about Cangrailer. So, Cangrailer is an anti-P2Y12. You're familiar with these drugs, but essentially the oral form. And we know that this oral form will have a delayed biological antiplatelet effect. Clopidogrel, which is the one we're going to use essentially in the elective phase, takes 6 to 8 hours to reach its maximum effect, with a half-life of 30 minutes and a residual effect of 5 days. For the forms we use together, ticagrelor or prasugrel, as Professor Montalesco and Professor Collet have shown, the effect is more rapid, but once again, you need several hours to achieve maximum biological efficacy, from 2 hours for prasugrel to 4 hours for ticagrelor. Conversely, cangrelor, an IV anti-P2Y12, has an almost immediate effect. In 2 to 5 minutes, you obtain a biological effect equivalent to 600 milliliters of clopidogrel, with a half-life also of the order of a few minutes, and an effect that disappears within an hour if you stop your medication. It's a bolus of 30 micrograms per kilogram and infusions of 4 micrograms per kilogram per minute, with infusions generally lasting 2 hours. So biologically, it works very well. Does it work clinically? It's a little less obvious, but there are effects perhaps of a niche nature, but effects that are present. If you look at Champion Plateform, a study that's getting on in years, over 10 years, they really gave a pro-cancer configuration. It was pro-cancerler because patients were either given cangrelor during their PCI procedure or a placebo, and they were all loaded at the end of the procedure. So it was cangrelor versus no pretreatment. And so the primary endpoint, which is a composite of ischemic events with no significant difference, even though it was numerically reduced, but there was this very interesting result, and which has made cangrelor much talked about. There was a reduction in stent thrombosis, particularly in the first 2 days, which diminished over a month, which is quite logical, since over a month it was more the effect of 2 doses of clopidogrel. Conversely, when the configuration is a little less favorable for cangrelor, as was the case in the PCI Champion, patients were either treated with cangrelor 30 minutes before PCI or a loading dose of clopidogrel 30 minutes before PCI. Here there was still a numerical reduction in events, but more significant effects, and an increase in minor bleeding with cangrelor. In the real world, we may now come across more and more patients who are no longer pre-treated. And here I show you the European Society's 2023 guidelines, which tell you to go ahead with aspirin. Eventually, you can consider anti-P2Y12 as pre-treatment in STEMI, which is debatable, which in practice is not at all what we do in our department and our SAMU, but these are the guidelines now. In STEMI, however, as you know, pre-treatment is no longer recommended. So, in practice, you're going to see more and more patients who are not pre-treated when they arrive on the control table. But this pre-treatment has an impact. This was again demonstrated in the Althea study, which compared ticagrelor with clopidogrel and showed that patients who received their loading dose, either clopidogrel or ticagrelor on the control table, a few minutes before PCI, were those who had the most periprocedural infarctions, which was the primary endpoint at 48 hours. Conversely, patients who received a loading dose several tens of minutes or even a few hours prior to PCI had a reduction in periprocedural infarction. There are also high-risk situations. ACS patients, especially STEMI patients, are often morphine-treated patients. We know that IV morphine will have an effect on digestive motility, may encourage vomiting, and this will translate into poorer platelet inhibition. And if you have a patient with a complicated ACS, cardiogenic shock or cardiopulmonary arrest, that's a disaster. There are so many patient-related and context-related factors that will interact with the efficacy of your anti-P2Y12 drugs that in practice, we don't really know if the patient is correctly treated at the time of PCI. That's why we have a randomized study. Well, it was presented to the ESC this year, but it's not yet published. It's called DAPT-CHOCME, and it only involved patients in cardiogenic shock, not pre-treated. This was a double-blind study. It was a really serious study. 605 patients, very serious. In terms of the biological primary endpoint, as expected, there was a biological efficacy of maximal cangrelor versus ticagrelor at the end of the procedure. Very good. Clinically, it was a little disappointing, with no significant effect for cangrelor at 30 days or 1 year, although there were some interesting secondary endpoints. I would mention the composite of cardiovascular mortality, infarction, urgent revascularization, or heart failure, which was positive. In terms of what interests us, the procedure itself, there were significantly fewer periprocedural complications in cangrelor. There were no stent propositions, a significant effect, and there was no increase in major bleeding. I mentioned drug-drug interaction. If you have to use cangrelor, remember that if you use ticagrelor as a relay, there's no problem. You can do it at the beginning of the infusion, in the middle, even at the end. Ideally, do it at the beginning, but there will be no interaction. If, on the other hand, you are using a tenopyridine, clopidogrel, or prasugrel, do it at the end of the infusion or even half an hour before the end of the infusion in the case of prasugrel. This brings me to my question: what are my indications for cangrelor? I offer these indications, which are of course open to discussion. I find that in the primary plastic issue of the CHS and the non-pre-treated patient, there's not much to lose and potentially a lot to gain. A fortiori, if you have a patient who is particularly severe, a STEMIN, an acute thrombotic load, and you have doubts about the efficacy of pretreatment if it has been done. The patient who has vomited, or the patient who is completely high on morphine, or the patient who arrives in cardiogenic shock in intubation because there is a cardiorespiratory arrest. If you don't have this emergency context, it's probably much more limited. And so I propose the ad hoc elective plastic issue. Then I say complex, difficult in a non-pre-treated patient, knowing that obviously the limitation is in this sentence. You're not necessarily supposed to do an ad hoc, complex elective plastic issue in a non-pre-treated patient. But if you do, eventually, the common trunk lesion, bifurcation lesions, ad hostant, I find that cangrelor can provide you with safety in your intervention, and you can then relay with an oral anti-PDO-Y12.
Thank you very much, Paul, for that very fine presentation. And to find out whether it's important to evaluate our practices and why we have a register of cangrelor use. And we'll ask Thibault to tell us about it. Thibault Lermusier.
No. To pick up on what Paul said, who today can question the place of a P2Y12 inhibitor in coronary plastic angioplasty? I think this Congress wouldn't exist if we didn't have this pharmacological class. The plastic angel almost died from not having this pharmacological class. Let me remind you of the level of evidence. The level of proof, and I've cited a few trials, is that when clopidogrel is given to medically treated heart attacks, it was a major Chinese study. COMET versus placebo, it was the comparator arm. Half the patients fibrinolized, by the way. This led to the indication of clopidogrel in thrombolyzed infarction. You have a reduction in cardiovascular events. Interestingly enough, this reduction is observed even with a time effect, i.e., for patients who were treated at the earliest opportunity. Continuing forward, can you explain the significance of a P2Y12 receptor inhibitor? When you double the dose, when a priori you reduce the proportion of patients with platelet hyporeactivity, for patients who have had an angioplasty in ACS, we reduce the risk of events, particularly infarction and stent thrombosis. Let me remind you of the 40 OASIS 7 trial, which used loading doses of 600 milligram, maintenance doses of 150 milligram in the aftermath of a coronary plastic angioplasty ACS. And finally, I'd like to remind you of the Triton trial. I could have used the Plateau trial, which showed that when you take a more potent P2Y12 receptor inhibitor, ticagrelor, prasugrel, you reduce the risk of ischemic events. I don't think we need any more evidence to say that we need powerful P2Y12 receptor inhibitors. Cangrelor's pharmacological properties are ideal, as Paul has already told you. It's really an on-off effect. The inhibitory effect lights up at the end of the syringe in 2 minutes. And you also have the possibility of recovering platelet activity within an hour of stopping your electric syringe. So choosing a P2Y12 inhibitor, this molecule has extremely valuable pharmacokinetic and pharmacodynamic properties. And that's why we finally developed, or at least carried out, clinical trials, and we'll come back to this. Just to return to the subject of P2Y12 oral inhibitors, can we still say that we have a well-defined strategy? In fact, it's not so obvious when you choose to give P2Y12 inhibitors before procedures, in particular for acute coronary syndrome. Well, that poses problems, and the studies have shown us that it poses problems with an excess of hemorrhagic events. The data on prasugrel have been well published, and this means that we are exposing a certain number of patients, for example, who do not have a final diagnosis of acute coronary syndrome to a molecule with hemorrhagic effects. This also poses a problem when pre-treating patients. To end up with patients who are referred for surgery and in whom surgery will either have to be delayed or performed on a P2Y12 inhibitor. But you're right. As the guidelines emphasize, pre-treatment is not recommended at all. It's class 3. But there is still the possibility of doing so in patients in whom we think the early invasive strategy will be successful. This means that we're not entirely clear about the timing of P2Y12 inhibitor administration, but once again, even if the recommendations leave no doubt about the fact that in routine practice, there's no room for pre-treatment. If we treat patients at the time of their coronary angioplasty, pharmacokinetic studies tell us that in any case, the effect is delayed 2 to 4 hours at least. 4 hours for clopidogrel and probably 2 hours for prasugrel and ticagrelor. Why isn't this molecule eligible for reimbursement? It has a major pharmacological effect. The target is interesting, and why, in fact, have studies been so negative? I was lucky enough to attend the FDA presentation made by the laboratory on the application for accreditation for Cangrelor. It was Braunwald, so I had his Bible on my bedside table, and I saw Eugene Braunwald come to present this study. And this study was extremely criticized. I'll run you through it quickly because Paul showed you the first two studies, Champion Platform and Champion PCI, which are ultimately negative studies. Well, we persisted with a third study, which ended up being positive. And you'll see that methodologically, this study posed an enormous number of problems. We compared Cangrelor to a reference clopidogrel 300 or 600 milligrams, and in various indications, acute coronary syndrome, ST+, non-ST+, but also stable NGORDs. So you see a very heterogeneous population. And in patients who had not previously been treated with P2Y2 inhibitors, particularly clopidogrel. So the study was positive at the end. It was positive on a composite endpoint that looks quite satisfactory. Death, infarction, stent thrombosis in particular. So we wonder why, in the end, there was no reimbursement following a positive trial. In fact, from a methodological point of view, this study is very concrete. In fact, the laboratory has been extremely accused of having a study that was carried out to the advantage of Cangrelor. And the first lesson, in fact, is that when you want to set up a study to favor your new drug, well, in fact, you're simply trying to reduce the efficacy of your control arm. This means that clopidogrel doses of 300 milligrams have been widely authorized in the control arm instead of 600 milligrams. As you can see from the figures in the end, patients on 300 milligrams actually had much higher event rates than those on 600 milligrams. That in the control arm, again, which we tried to disadvantage, well, we tried to delay the loading dose of clopidogrel as much as possible. And so the post hoc analysis of this study shows that in the end, in these patients, the more clopidogrel was delayed, the greater the risk of events. And in fact, this study left no room for the new P2Y12 inhibitors, which today represent the modern treatment strategy. No ticagrelor, no prasugrel, no GP2B3A inhibitors. And then I told you an endpoint at the end which is ultra positive, but in the end, this endpoint includes periprocedural infarction, i.e. globally, troponin elevations. As you can see, even patients with stable angina had exceptionally high event rates. FDA labeled corn products as corn, denying reimbursement. They were being denied reimbursement for acute coronary syndrome. And of course, in fact, the pharmacokinetic and pharmacodynamic data, which are exceptional for this drug, in fact, cannot justify reimbursement in view of the methodological biases of this study. So in practice, what do we do? In practice, finally, I'd like to pick up on what Paul said and what appears in the ESC recommendations today. A priori, what are the right indications? Acute coronary syndrome, of course. Patients who are naive to P2Y12 inhibitors, who are candidates for immediate angioplasty, and who therefore more often have steremia. Patients in whom oral administration is not possible due to vomiting or intubation. And then, probably, situations where oral absorption of these P2Y12 inhibitors is extremely delayed. Cardiogenic shortness of breath, cardiocirculatory arrest, why not? My last situation, and this is a rather funny example, was 15 days ago. I knew I was dealing with this problem, and I was on call on Sunday. I was told that the patient was ST+, 56 years old. We had no information, no history. He went into cardiac arrest in front of a witness. He was massaged immediately, and finally, we had good resuscitation criteria. The patient arrives, intubated and ventilated, and the EMS doctor tells me, I'm not sure where the nasogastric tube is. He's not shocked, but the first blood pressure, which is real life, is 9.6. So we say to ourselves, we don't really know how it's going to turn out. We do an ultrasound to sort things out, and I have the intern with me who tells me, I wonder if I have a post-massage pericardial effusion. Well, and the hortensia, it's not fatty bangs, I don't know. But hey, maybe we won't hang around. We're still going to install the patient and unblock the IVA, so that's what we did. But in the end, we're really in the situation where we're wondering if we're going to have to manage an extremely severe hemorrhagic complication in a few minutes, namely a hemopericardium. This patient is probably in shock or pre-shock. He may require ECMO-type assistance in the aftermath. He is 56 years old. What about oral absorption in these conditions? Probably not. Well, that's the right indication for me, the perfect indication for an oral inhibitor. VIR, sorry. So, once again, for me, there's no doubt about one thing. The pharmacological properties are ideal, and the target is well validated. In fact, we all know that P2Y12 is useful in coronary angioplasty. There's no reimbursement, we agree. And we also agree that there isn't a high level of evidence for routine use. That's why we've tried to take stock of cangrelor's use. We know that some centers are extremely active. Some refrain from using it entirely. We also know that the reasons behind this are mainly economic, i.e., pharmacies say that your drug doesn't have a sufficient level of evidence to make it available. And so finally the idea is, under the aegis of both the GRCI and the USIC group, to try to collate all these patients retrospectively in the first instance and to try to take stock of practices in the 4 labs on the subject. In the 4 labs on the use of cangrelor. Thank you very much. Thank you very much, Thibault.
Talk to you. I'm delighted to introduce Professor Anne Gaudier, who is an anesthesia intensivist ready to corner us, as this molecule is mainly used in acute phase or complex angioplasty patients, rather in the acute phase or in patients undergoing very complex angioplasty. But Anne has done a great deal of work on unstable coronary patients who may or may not require emergency surgery. And it's true that this is a real problem for this patient. And I'm going to ask Anne to tell us a little about the state of the art in this area. Thank you, Anne.
Winter, thank you for your invitation. It's always a pleasure to discuss perioperative medicine with the other specialties concerned by the subject. That's right. The concept of perioperative relay by an intravenous antiplatelet will concern a very small number of patients who are at very high risk of thrombosis and who have a dual characteristic. On the one hand, they have dual antiplatelet therapy for a recent stent, or characteristics that you would call very high thrombotic risk. On the other, they're going to require an invasive procedure, non-deferrable, and this is a major point, either at intermediate hemorrhagic risk, i.e. requiring discontinuation of the Y12 antipeptic, or at high hemorrhagic risk. These are still the rare situations that will require discontinuation of dual therapy. We are therefore in a situation of high thrombotic risk, both because antiplatelet therapy is stopped or modified, but also because surgery, by generating inflammation, leads to a procoagulant state that is highly conducive to cardiac events, especially in the post-operative period. Once the oral Y12 antipeptic is stopped, the idea is to follow it up with an infusion of a Y12 receptor inhibitor until the surgery is performed. Surgery, since the treatment will be stopped in the hour preceding surgery. And this is a major point. We cover the preoperative period. And the idea is that by covering the preoperative period, we'll also be able to benefit the father and the postoperative period. And that's a point to bear in mind. We treat pre for a benefit that will essentially be postoperative. And we do all this in the hope that we'll have few side effects. Essentially a low risk of bleeding because the platelet inhibition induced by cangrelor is a powerful inhibitor and we won't have too much thrombocytopenia. And then there's the question of which population exactly, since we're talking about a small population. Technically, how do we go about it? We start by stopping the anti-P2Y12 orally with the classic. A final dose at D7 for prasugrel, D5 for clopidogrel and ticagrelor, although D3 for ticagrelor is debatable. We wait 24-36 hours and introduce cangrelor, which we continue until around 30 minutes to an hour before surgery. The surgeon operates, mostases and cares as usual, and in the post-operative period, there's really no room for cangrelor. Oral treatments are resumed as soon as the hemostases allow, and in rare cases the enteral route is not available. So cangrelor once again finds a place, albeit a small one. At one time we tried thyrophibin, which had the same peak benefits as cangrelor, 5 minutes versus 2 to 3 minutes. It was very competitive, but thyrophibin is hampered perioperatively by its long half-life. Long is a relative term, meaning 2 hours, but it's 2 hours, whereas cangrelor has a half-life of 3 to 6 minutes, which explains why we can stop the infusion 30 to 60 minutes before going to the OR, with platelet function recovering. So we have no randomized trial demonstrating the clinical benefit of cangrelor in the context of bridging. But we do have BRIDGE, which is indeed a randomized trial showing the feasibility of this method. It involves 200 patients, a very small group compared with your usual studies, who are on dual antiplatelet therapy and who will require coronary planting within 2 to 7 days. So we're in a hurry. Patients have to stop taking oral anti-P2Y12 gold. They are then randomized to receive either cangrelor or placebo, with treatment initiation a median of 29 hours after the last oral dose. The infusion continues, and they stopped it a median of 3 hours before going into surgery, and they go to the operating room. There's a whole biological analysis part using the Verify Now, a delocalized biology device that gives an equivalent of platelet aggregation, but on 100 total. It's evaluated in terms of platelet reactivity. Here, the cartridge testing anti-P2Y12 240, which is the threshold used in this study. The first point is that once you've stopped taking the drug orally and started intravenous treatment, the black spots are cangrelor. You see that platelet reactivity collapses and remains low and stable throughout the infusion period with little inter-individual variability. In any case, all patients are below the safety threshold, so it's biologically effective. When you press the off button on the electric syringe, it's incredible. The half-life was short and platelet function recovered in a very short time. And all patients are back above the threshold, allowing surgery to be carried out without an increased risk of bleeding. In terms of clinical events, the number of patients was very small. So there was no difference in hemorrhagic events, especially as platelet function was recovered. No difference in ischemic events. Nevertheless, in neither case was it the ulva, reflecting the fact that this is a very high-risk period. Behind this, we have very small series of real lives, very small series. Here we have 24 patients treated with dual antiplatelet therapy who will need to go into the operating room. This is a very high-risk situation, since 54% of patients have an ACS less than 3 months old. A quarter will have a STEN less than 1 month old. And the idea is just to remind you that while we're targeting post-operative events, there are also pre-operative events. Here you see a death from cardiac arrest 3 hours after the electric syringe was switched off. So the preoperative period also counts. This second series, 60 patients, dual antiplatelet therapy requiring cardiac surgery, essentially non-cardiac surgery. They will have relays with different molecules, including cangrelor. I've put together this series mainly to show you perioperative complications. 2 non-fatal infarctions after cardiac surgery, 1 stent thrombosis after non-cardiac surgery, 4 infarctions. We were working with a group of 60 patients. My message here is that in the end we have a real difficulty in managing these patients, both in terms of the risk of bleeding and the risk of thrombosis. And cangrelor could be a solution, although this has not yet been formally demonstrated, as there are no randomized trials. The GHP, the perioperative interhome hemostasis group, as early as 2018, had positioned cangrelor as an option in situations where dual therapy was stopped in the first month after stent insertion, to be discussed on a case-by-case basis. And finally, Jean-Philippe Collet, who was part of the GIHP, was a pioneer in this position. My concluding slide is your recommendations, the European recommendations. The discussion on bridging is aimed at patients treated with dual antiplatelet therapy who are going to be exposed to bleeding risk surgery requiring discontinuation of anti-P2Y12 in a context of high thrombotic risk, based on your own characteristics and definitions. In the case of surgery that cannot be deferred, and this is a major point, the decision to defer surgery must first be discussed. And indeed, in your recommendations here, cangrelor has a place in bridging. Now, collectively, we need to build up studies to demonstrate that there is a benefit to this, because it is associated with a cost and a potential risk of bleeding. But above all, we're expecting a lot from it in terms of thrombotic risk. Thank you very much.
Thank you, Anne, for keeping to the timetable. We'll take 1 or 2 very brief questions if there are any in the room. Yes?
So at least 5 days, I don't know, but effectively, let's suppose he's being treated with clopidogrel or ithicagrel, or you do a last dose at D5, that can be at home. They say that in the first 24 hours, you do nothing. You'll have to decide whether to introduce it at the 24th or 36th hour. Let's say we introduce at the 24th hour. In fact, when you introduce it, it has to be in hospital. So on the evening of D4, he has to be hospitalized because he's going to need an electric syringe. Depending on the facility, you need to think about where you can administer the cangrela. With us, typically, it's not in a normal room. It's either a continuous anesthesia intensive care unit or a USIC unit if the cardiologists in the facility wish to administer these products. But the continuous electric syringe cannot be used for life.
So it's 4 days at least?
There's one more question from the floor. Go ahead with the mic.
Hi, I wanted to ask a question about ventricular assistance. Given that it's the same principle as the contribution balloon, will we only be able to recover our old consoles to make them work?
You want to make an assistant? It has nothing to do with the topo now. So it's the pool sketch again, the sketch from the beginning. Yes, and that's it. So I don't think it has anything to do with the counterpulsation and assistance we see with IVAC. It's really very different advice. And then, if you want to get your console back, that can be a good way. But in any case, in terms of evidence and at a scientific level, I think it's really two approaches that aren't the same. Yes, we can. It's the same console, exactly.
Little baby Paul, I'd just like to come back to this slide I've put up, which is the relay, which is really important in management. I'd just like you to remind us, one or other of you, how you take over when the infusion stops.
Perfusion. As Paul reminded us, the explanation is a bit strange, actually. We have molecules that are probably very, very close in terms of sites of action between cangrelor and ticagrelor. In the case of clopidogrel and prasugrel, the explanation lies in the fact that they are prodrugs which are transformed into an active metabolite. If you remember, these drugs are metabolized in the liver, and that this active metabolite has a very short half-life in the circulation, and that the presence of ticagrelor or cangrelor, in fact, it causes a problem of binding of this active metabolite to its site, which means that it is eliminated rapidly. So what we were able to show in the trials is that the presence of cangrelor ultimately impaired the efficacy of clopidogrel and prasugrel. Paul, you can correct me if I'm talking nonsense, but most of these trials, once again, are not clinical trials. So they're trials based solely on aggregometry data or rapid platelet reactivity tests. But overall, in fact, there's no problem with the cangrelor-ticagrelor relay. However, there is a small precaution concerning ethionopyridine, which is ideally given at the end of the infusion. We reload the patient at the end of your cangrelor infusion. Okay, this is really important. Yes.
And so it's a biological effect. If you're ever doing cangrelor and you think, no, I didn't load at the right time, the patient isn't going to thrombose immediately. But to get the optimum effect, since that's kind of the point, it's an expensive molecule. And so its justification is to have the best inhibition. So it makes sense to use this rationale.
Yes, it does. And it's still simpler to use the small case. You're less likely to make a mistake at the...
Yeah, small case recall. It's at the beginning, in the middle, or at the end, as you like. No big deal.
Less. Thanks to all three of you. Frank, come on. Come on, Frank. Wait, I'll bring it.
Pre-treatment, the ROCOs tell us that we should no longer pre-treat patients who arrive in the Coro with a non-STEMI or stable angina. They are sometimes hospitalized the day before in an emergency, and we still do a lot of ad hoc angioplasty, which may not be good practice. So they often arrive on cardiac alone, and we know that the absence of pre-treatment prior to angioplasty can favor ostensive thrombosis, and we now have studies, in particular with the France PCI clock, which we presented at the ESC, so you're giving everyone Cangri now.
So, no, in short, already no, but because on pre-treatment, ultimately, I think it was still, well, overall, and my center too, we were not convinced of the relevance of pre-treatment in ACS, ST1, and STEMI. In STEMI, on the other hand, there has been a change in the guidelines, whereas Professor Montalesco's studies had shown that there was a real benefit to pre-treatment in preventing stent thrombosis. So, in our practice, STEMI patients referred by a SAMY are systematically pre-treated. So the question doesn't arise. In ST1 ACS afterwards, that's what I suggested. What we've suggested is to prolong the treatment of particularly high-risk patients, where I think there's a real benefit to cangrelor. Then, if you have unstable angina without elevated troponin with a lesion of the middle circumflex, oral ticagrelor works, oral prasugrel works. Studies have shown this. You can also give the orodispersible form under the tongue, which is also very practical, administered on the Corot table. And in terms of the impact on periprocedural infarction in Alpheus, you've seen that the time needed to start significantly reducing risk is at least 12 minutes. So if you estimate that you're roughly 20 or 25 minutes between the time you load and the time you do the Corot, which is just the time it takes to set up all the equipment, that works too. But cangrelor still has a real place, a real rationale on non-pre-treated ACS, particularly at the risk of a large thrombotic load.
Thank you all three. Unfortunately, I think it's time to close this micro session and move on to the transition to the HBR patient, who is also a very high-risk patient. I'd like to ask Clément SERVOZ to join me and Gilles Barone to join us. And Clément, it's Seth Zappit for you to tell us a little bit about antithrombotic management. There's a lot happening with the HBR patient at the ESC, so provide updates on the new developments.
So, we're going to talk about the HBR patient. And it's a particularly interesting question because this HBR patient is one we come across every day in our 4 labs, probably often without realizing it. But when we look at the HBR criteria, ultimately, it's elderly patients, cardiac insulins, renal insulins, who are on anticoagulants, who have a discrete amine, discrete thrombocytopenia. In short, these are patients we have to treat on a daily basis, and we can't really identify them well enough. And that's what we're seeing in European registries and studies. It represents more than 40 to 45% of patients who are treated and revascularized. We have recommendations for the management of these HBR patients. The first situation is chronic coronary syndrome, and we know that today, with modern angioplasty techniques, imaging, and latest generation staging, these are patients who ultimately have few ischemic events. Instead, it's the bleeding event that can impact the prognosis of these patients. And so we have quite clear recommendations for these patients. So the first thing to do is to assess our patient's risk of bleeding. And if we're dealing with an HBR patient, it's perfectly legitimate. It's a grade 1A recommendation to start taking dual therapy for 1 to 3 months. In the context of CSS, the second situation is acute coronary syndrome. Here, we know that patients are more likely to suffer ischemic events within a year. Secondly, the studies that have been carried out have focused more on hemorrhagic events and a little less on ischemic events, which means that the levels of evidence are a little lower. But the fact remains that, once again, in HBR patients, we have the possibility of shortening dual therapy from 12 months to 6 months, or even 3 months, or even 1 month, even what has been proposed. There are also strategies for de-escalating dual therapy, in which case clopidogrel is preferred to ticagrelor or prasugrel. In short, here too, in the context of acute coronary syndrome, in patients at risk of bleeding, it is perfectly legitimate to modify antithrombotic strategies. And so at the present time, we have a whole host of studies that have been tested in the context of ACS. So we have the classic strategy and the 12-month dual therapy strategy. We have the strategy of de-escalation and switching to clopidogrel versus ticagrelor or prasugrel. There are shorter strategies with 6 months of dual therapy. Strategies that are a little bit reversed, where you have 12 months of dual therapy, then you keep the P2RIG12 inhibitor to have its anti-aggregation effect over 12 months, then at the end of the 12 months, switch back to aspirin. We still have strategies in the pipeline which will test aspirin alone as monotherapy. In any case, we have a whole range of possibilities to offer our patients, but we can also ask ourselves which one will be the best, and they haven't been compared. But when we look at our own practices, they're probably a long way from these studies and recommendations. And when we look at the France PCI registry, it's in the context of SCC. Out of almost 9,000 procedures, we can see that therapies of 6 months or less represented only 16.4% of patients. So finally, in our clinical practice, we're a long way from shortened dual therapies. And in this very study, we saw that a significant number of patients were on dual therapy for more than 12 months in the context of chronic coronary syndrome. And we also saw in these sub-studies that patients at high risk of bleeding, patients who had events, did not shorten their dual therapy. So clinical practice is still a long way from the recommendations and studies that lead us to shorten dual therapy. So in conclusion, when it comes to dual therapy at the present time, the message is really to offer a tailor-made dual therapy. We're going to have to get away from the paradigm of 12-month dual therapy for ACS and 6-month dual therapy for CTS. 4 points that may be of interest. To keep in mind at the end of this, one is that the aim is really to prevent the bleeding event rather than suffer from it. In other words, the aim is not to wait for the gastroenterologist to call us and say, there's been a bleed. Can we reduce the combination therapy? In the end, the prognosis for the patient is already made and we arrive too late. The aim is to anticipate and prevent this hemorrhagic event. That's what's going to impact our patient's prognosis. Secondly, the risk of bleeding increases linearly with the duration of dual therapy. That's why we need to think about the ischemic and hemorrhagic balance of our patient and decide whether to do 12 months, 6 months, or 3 months, 1 month of dual therapy, depending on the patient's clinical situation. Finally, as cardiologists and nutritionists, I think it's going to be important to learn how to identify these patients at high risk of bleeding. We've tended to focus on ischemic events. We know we've put in a lot of stents, we know we've done complicated procedures, and we can see that. But when it comes to patients at high risk of bleeding, it's hard to identify and capture them. So perhaps we need to make routine use of scores and so on. But in any case, cardiologists and nutritionists need to work together to identify these patients so as to modify the duration of dual therapy. Finally, we have seen that there are a number of different situations. In SCC, there are high-grade recommendations that dual therapy should be shortened. In SC, we have more and more studies showing that it's feasible with slightly more atypical regimens. And that's the last thing that's important, and that's that it's going to require education on our part for our cardiology and nutrition correspondents, because we're going to be faced with increasingly complicated regimens. We'll be dealing with 12-month, 6-month, 3-month, and 1-month dual therapies. We'll also have to switch to aspirin after a month and things like that. In short, we're going to have to monitor patients over a fairly long period of time so as not to end up with patients on ticagrelor for 2, 3 or more years. In any case, we'll need to monitor patients and educate our correspondent cardiologists and attending physicians. Thank you very much.
Thank you very much, Clément, for your clear presentation. And now we'll ask Jacques if, with the HT Supreme stent, we can further reduce the duration of dual anti-aggregant therapy.
Thanks to Kim. So, in effect, I'm going to talk to you about a stand that's a bit confidential at the moment. These are my areas of interest. There's nothing original about the platform. It's an 80-micron cobalt chrome platform with sirolimus and a biodegradable polymeric layer. But this polymeric layer is what really makes this new device original, with a coating that's a French innovation for once. It's an innovation from Grenoble and involves modifying the structure of the polymer a little. There will be 2 layers of polymer thanks to electrografting. I won't go into the technical aspects of electrografting because I'm not qualified to do that, but we apply an electric current that creates a kind of brush that attaches itself to the chrome cobalt and acts as a Velcro fastener, enabling us to apply the biodegradable polymer on which the sirolimus molecule is embedded. The enormous advantage of this is that the sirolimus is released extremely early, and that's what's important, because what we want to do is inhibit the cell proliferation that keeps the patient nauseous, and so we're going to inhibit it very early on, because this is currently the platform that enables us to achieve the earliest release. On the other hand, we're also going to limit the release of sirolimus, because this sirolimus drug is also toxic at some point, because it prevents the proliferation of endothelial cells. These endothelial cells are responsible for healing the artery. So we're going to have a double beneficial effect with a polymer that will then resorb very rapidly in less than 30 days. These kinetics are a particularly innovative element and will enable us to consider a reduction in dual therapy for these patients. As Clément said, this is one of the alternatives. The less time we spend on dual therapy, the better patients will do, with fewer bleeding side effects. So do we have any scientific proof? It's still coming in. We already have quite a lot with 2 major studies. Pioneer 3, which compared this device to everolimus and stent Xians. And then there's Pioneer 4, which has come up with an innovation. In all commercial patients, we only do 1 month of DAPT and then leave these patients on platelet-regulating monotherapy with ticagrelor. And indeed, when you look at these 2 studies, the patients all benefited from the implantation of this stent. Pioneer 3 showed excellent results at 5 years when compared with the Xian stent. But what's much more interesting, which was presented at the ESC in Madrid this year, is the bleeding rate. We have very little bleeding, which is extremely reassuring. But above all, we have very little corn. And when we compare an attitude with monotherapy and an attitude with dual therapy, we can see that monotherapy actually does better in terms of corn. So the effect is indeed encouraging. So we haven't quite reached the significant threshold. But that's probably because we're still missing patients from Pioneer 4 who haven't yet been included in this subgroup analysis. Above all, there's still a lot to come behind the HT Supreme with this electrogriffage concept. It's the 2nd generation with CD31, which will probably enable us to completely limit thromboinflammation and, above all, to reduce the risk of thrombosis. Above all, we may be able to avoid revascularizing these patients with long-term aspirin. In other words, we'll give them a shot of aspirin to start with and then no more aspirin. We'll just leave them on a monotherapy of antiplatelet agents with a DP2Y12 inhibitor. That's what I wanted to tell you about this stent, which also has a structure that adapts perfectly to complex lesions. It's easy to open the mesh and the safety is really superb. Thank you very much.
Thank you very much, Jacques. The transition has been made. We'll now move on to randomized data, registry data. We're fortunate to have Gilles with us to enlighten us.
Good afternoon, all. Thank you for having me. It's great to be here discussing technology. So, you get the idea. The Grenoble CEA and the Alchimedica company developed the particular technological structure which is now distributed by Sinomed. And so we have seen all these little particularities, electrografting. In fact, we also saw the monolayer that remains after a very rapid release. The endothelial cells, in fact, go much faster on the test strip than on bare stands, which are normally drug-free. So it's very interesting, something that has been observed. So I have to ask you, do all these technological peculiarities have any repercussions on our practice? Well, actually, there's a program, a big program, as we've seen, of development. And as you know, our technologies and advances have to be found through clinical studies. This has been the case with the various studies we're going to see, which we'll quickly go through, and then we'll get to the hard register. So the first study is a fairly simple one. It uses OCT technology to see the recovery rate in relation to the sciences. And in the end, if I show you the 16 patients, as you can see, it was really proof of concept. And we see that, in fact, the speed of recovery, what we had seen on endothelial cells, is found on real humans with OCT technologies. Secondly, we compared ourselves to the best stand on the market, OCT, with a comparative study with a normal endpoint, i.e. cardiovascular death, non-fatal infarction, and emergency revascularization. And we can see that there is no difference with B anti-regulation, which was standard at the time of the study. At 5 years, as I showed you, there was no difference. We have non-inferiority, which is continued at 5 years with analysis. So we're on the safe side compared with the best, with a stand that you know very, very well. And then there's Pioneer 4, which is really interesting. Pioneer 4, because here we come up with the theory of saying, well, we're going to do a short by anti-regulation with 1 month aspirin P2Y12 and leave the P2Y12. You know that some people are going to push this, as we said earlier, as a possible strategy. Some believe in it more than others, and that's what this study is all about. Endpoint in non-inferiority for always the same and something of analysis on a first analysis with the heart beating score, risk score, which predicts the risk of thrombosis and the risk of bleeding depending on patient characteristics. This analysis of people already included shows that in the end, the thrombosis rate cannot be predicted, i.e. it is much lower. It is not at all related to the thrombosis score, i.e. there is an effect. There's something that takes them out of the usual event. So very interesting signal and hemorrhages, we can predict them. On the other hand, there are fewer than usual, so that's very interesting. Of course, I've included the Pioneer 4 study. Why was there an interim study presented by Mr. Sirius at the ESC? Because it was the Europe and Japan favor alert. In the end, they stopped the study. We stopped to see if there was any danger to QFR. There was none. We're continuing and we'll have the final results. And so we were asked to work on the high bleeding risks. That's what we did. We've designed a single-arm study on a registry that will focus on identifying high-risk patients. And so on Monday, we started at our center. We put up signs everywhere. You know, you have the arc blending risk application. In the end, when you're in the room, the application doesn't work at all. I can tell you that. Put up signs everywhere saying what the minor risks are. Oh, you need two minor risks. You're at high risk of bleeding. So the 75-year-old patient flow less than 60 milliliters per minute. He's at high risk, so you find them pretty quickly. And these are patients who have had events in the studies. We follow them for 1 year. We relied on the MasterDAPT composite criterion in randomized studies for an event rate that includes both ischemic and non-ischemic events, occurrences of reduced blood flow and bleeding events. So we're going to include 200 patients. And we calculated non-inferiority, and above all, superiority. Despite unequal arms, we expect similar thrombosis rates and study outcomes. And hopefully we'll most likely witness it soon, we anticipate. A very abnormally low rate of thrombosis on bleeding complications compared with patients at risk of bleeding. That's the plan. We'll conduct the study and inform you. Grateful to all centers that agreed to participate. Thank you very much.
Thank you very much for this very fine presentation. And I'll leave it to Jacques to conclude this three-part session. Hemodynamics for the most complex plastic issues. Pharmacology to try and reduce the risk of bleeding and ischemia in patients undergoing surgery. And finally, how, through strategies, molecules, and stents, we can further improve the risk of bleeding in exposed patients.
Jacques, it remains for me to thank everyone. It's been a bit of an uphill battle against the clock. Claire, I'm sorry, she's in the control room. We were only 44 minutes late, but we left 5 minutes late. So I think we made it, and we hope to stay on top of the podium. Thank you all very much. The Congress isn't over yet. There's a buzz at 2 p.m. There's another studio coming up soon. And above all, there's a final live from Marseille on a live coroner in a patient at risk of bleeding. So let's talk about it again. Thank you all very much.